Bismillah ar-Rahman ar-Rahim. First of all, I'm so honored to be presenting this lecture at this great event. Thanks a lot to Dr. Afaf Hamid and Dr. Mustafa Saadani. I'm Maged Hamza, an assistant lecturer of psychiatry at Alexandria University, and now I'm going to discuss the role of psychotropic drugs in COVID-19. So, how did research actually start in this area? By start of the pandemic of COVID-19, most of the doctors, especially in France, were preoccupied by psychiatric patients, expecting that they would be at high risk of infection with COVID-19. This made them start creating special units in hospitals to care for those patients. They actually expected this high risk in psychiatric patients because of the potential difficulties they may face with protective measures, because of the limited access to health care, also because of the close living conditions of patients residing already in psychiatric wards, and high risk would be expected psychiatric patients because, as we know, they have a lot of comorbidities, including diabetes and cardiovascular disease, which make them more vulnerable. But to our surprise, actually those specific special units for psychiatric patients remained empty over the pandemic. Even during the most severe stage of the pandemic, it still remained empty. This observation actually led doctors to think whether the psychiatric drugs those patients are already receiving might offer some sort of protection against coronaviruses. With further research, they found out that 10 of the 18 most commonly prescribed psychiatric drugs, whether antidepressants, antipsychotics, or anti-anxiety medications, already have known antiviral properties. For now, there are 4 different types of therapies that are already FDA approved against COVID-19, including remdesivir, the plasma from recovered patients, the monoclonal antibodies, and the steroid dexamethasone. 3 of them are already highly expensive, and the 4th steroid option might backfire and suppress the immune system. All of this give more motivation towards the research area in psychotropic drugs' effects in the COVID-19. A recent study published in the Journal of American Medical Association found that people who were given fluvoxamine within 7 days of developing COVID-19 were less likely to have a drop in their oxygen levels and even less likely to be hospitalized than people who received placebo. For the fluvoxamine group, there were 80 individuals and none of them had clinical deterioration, while in the placebo group, there were 72 people, 6 of them already deteriorated. This is a statistically significant difference, and it suggests that fluvoxamine may be preventing the clinical deterioration, at least in terms of drop in the respiratory function. Of the most commonly researched drugs in this area are the Ssri and then the antipsychotics. So we'll start by discussing the mechanisms of action of Ssri regarding COVID-19, and then we'll proceed to the antipsychotics. Okay, the first mechanism of action for Ssri in cases of COVID-19 would be the sigma receptors. Actually, 2 different studies were conducted on April and October 2020, and they both concluded that sigma receptors is a key location for the virus to bind and manipulate the human cell, and they are very crucial for the survival of the COVID-19 virus. So it's not important where the virus enters the cell, where it enters at the ACE receptor, as actually it appears that once the virus enters the cell, it uses sigma receptor to turn the cell into a virus-producing factory. Of the examples of drugs we already use as sigma agonists are the fluvoxamine and the donepezil, while as an example of sigma antagonists would be the haloperidol and the sertraline. The 2019 study showed that mice lacking sigma receptors were more likely to die from hyperinflammation, while mice given fluvoxamine were more likely to survive. With the news of deaths from hyperinflammatory cytokine storm of COVID-19 emerged on March, they actually started a clinical trial for fluvoxamine, and the data were promising. Also, we are expecting a larger phase 3 study. So, the mechanism of action of fluvoxamine here is that it upregulates the interleukin-10, which is one of the anti-inflammatory cytokines, moving the balance towards more anti-inflammatory than a pro-inflammatory balance. Fluvoxamine actually does this mechanism through its effect on sigma receptors, modulating the SARS-CoV-2 induced hyperinflammatory state. Another evidence regarding this mechanism of action was that researchers reviewing the medical data in the US regarding 740,000 COVID-19 patients found out that those patients who were on psychotropic drugs targeting sigma receptors were half as likely to need mechanical ventilation than other patients already on different types of drugs. The second mechanism of action regarding the SSRIs would be the lysosomal tropism. Actually, the host cell entry of SARS-CoV-2 virus, which is implicated in COVID-19, displayed the initial step during host cell infection and viral replication. Effective blocking at the stage of the disease would be very likely resulting in a successful prophylaxis and treatment. So several studies have been conducted regarding the entry route and therapy options for treating SARS-CoV-2 infection, as it enters through binding to the spike protein on the ACE2 receptor, and then the host cell serves function as a receptor for the virus. After then, the virus membrane fuse with the host cell membrane through a protease-mediated cleavage of the ACE2 spike protein complex. This activation actually occurs at the level of lysosomes through their cathepsin protease enzyme, and drugs targeting this protease would be a very effective option regarding the COVID-19, as we will further discuss. As we already reported that this cleavage-mediated fusion occurs within the lysosome, catalyzed by the cathepsin. Therefore, inhibition of the cathepsin is a promising treatment approach for SARS-CoV-2. Those drugs that would be an effective options regarding this mechanism would be the fluvoxamine, the chlorpromazine, and the fluoxetine. So 2 SSRIs besides one typical antipsychotic. Actually, those drugs are significantly less toxic than the chloroquine and hydroxychloroquine, which are already used in cases of COVID-19. This is another study published on April 2021. It also discussed the same mechanism of action of lysosomal tropism regarding different psychotropics and antihistaminics. Again, lysosomal agents are agents or compounds that accumulate in lysosomes or an acidic subcellular components. One of the drugs that actually function in cases of SARS-CoV-2 infection through the mechanism and well-known used drug in this area is the hydroxychloroquine. Of the psychotropic drugs category involved in this mechanism in this study were effective in such mechanism were the clomipramine in a very recent study, the chlorpromazine, as mentioned before, and fluoxetine, haloperidol, imipramine, clozapine, and the antihistaminic cyproheptadine. Besides those, there are 3 different drugs not studied in this data set, but still can be considered lysosomotropic, is the selective estrogen receptor modulator, the clomifene, and regarding our drugs is the vortioxine, the new antidepressant drug, and the acinapine, the atypical antipsychotic. All of the 3 are considered lysosomotropic components, and combinations of them is much more potent than each of them alone. As a conclusion of this study, that some antihistaminic and psychotropics could protect humans from infection with SARS-CoV-2, so they can be a prophylaxis, not just treatment. And this can occur by affecting the different steps of viral infection of the cell, whether affecting the endocytosis, the membrane fusion, or inhibiting the catalytic site, and the interaction to direct binding of some specific membrane receptors. Actually, some of the antipsychotics were reported to bind directly to the ACE2 receptor, which is the location of binding of the SARS-CoV-2 virus to the human cell. This is a study discussing the third mechanism of action of different SSRIs, which is different level of melatonin. The study was published on June 2020. So, melatonin can decrease the inflammation cytokine storm, as we will discuss in the following diagram, Also, melatonin exposure post-intubation is associated with a better and positive outcome in COVID and non-COVID patients. So what is the relation here between melatonin and SSRIs? Actually, fluvoxamine can elevate the levels of melatonin through inhibiting the CYP1A2 enzyme, which is a member of Psychotropic 450 superfamily of enzymes. As we can see from this diagram, those are the different components leading to the cytokine storm, implicated in the different complications of cases of SARS-CoV-2 infection, and the different effects of melatonin on those different components. Melatonin would affect the inflammation through increasing the anti-inflammatory cytokines as the interleukin-10. It would also modulate the immune response through decreasing the neutrophils and lymphocytes. Besides, it also affects the high oxidative stress in such cases by having an antioxidant effect, all of which would somehow control the cytokine storm in those cases. A fourth mechanism of action is the effect of SSRIs on platelet aggregation. What happens is normally platelets lack the enzyme to synthesize serotonin, so they depend on the serotonin transporter to uptake the serotonin from the plasma. During thrombosis, platelets release serotonin, inducing platelet aggregation and recruitment of neutrophils. SSRIs actually increase the bleeding time, and they also reduce serum serotonin by more than 80%, plus they also reduce the neutrophil recruitment. So platelets of individuals already on SSRIs show decreased aggregation, and those patients have measures of coagulation and homeostasis lower than patients who are not on those antidepressants. So what is the clinical significance of this? Simply, as we know, in cases of COVID-19 or SARS-CoV-2 infection, one of the complications is cerebrovascular accidents, and a lot of them, due to the increased coagulation, are put on therapeutic anticoagulants. The problem is the increased risk of internal bleeding in such cases. So SSRIs, more specifically fluvoxamine, can be a better inhibitor of blood clotting in a more safe way. A fifth mechanism of action is inhibition of the acid sphingomyelase. Some SSRIs as escitalopram and fluoxetine, other antidepressants as amitriptyline, inhibit this enzyme. This enzyme is responsible for the conversion of sphingomyelin to phosphorylcholine and ceramide. What is the clinical significance of this? Simply high levels of ceramide in the cell membrane facilitates viral entry. So reduction of ceramide may completely prevent the infection and may be prophylactic. So therefore, functional inhibition of acid sphingomyelase is another avenue for viral control by antidepressants. Mechanism of action number 6, and the last of those mechanisms specific to SSRI, is the mast cell degranulation. Actually, mast cells express the angiotensin converting enzyme ACE2, which we already mentioned that it is the main principal receptor for SARS-CoV-2 entry, so it defines a route for entry of the virus. Also, postmortem lung biopsies of COVID-19 patients linked the pulmonary edema and the thrombosis to the activated mast cells. What happens is that antidepressants decrease the histamine release from mast cells. They cause mast cell degranulation, and thus SSRIs as fluvoxamine and fluoxetine can reduce the cytokine storm in COVID-19 patients through the atypical response of mast cells to the SARS-CoV-2. So, as we have discussed, there are a lot of different mechanisms of action for SSRIs, more specifically fluvoxamine in cases of COVID-19. And for now, there is an 880 patient randomized study underway. Most probably will provide us with more definitive answers. So, out of caution, the practice guidelines for now urge caregivers to consider administering fluvoxamine only on those COVID-19 patients who are at highest risk of progression and who do not have access to one of the monoclonal antibodies that are already authorized by the FDA. So, as we have mentioned, there are a lot of different mechanisms of action of SSRIs and more specifically of fluvoxamine in cases of COVID-19. For now, there is an 880 patient randomized study underway. Most probably will provide us with more definitive answers. So, out of caution, the practice guidelines could urge caregivers to consider administering fluvoxamine only to those COVID-19 patients who are at the highest risk of progression and who do not have access to the FDA-approved monoclonal antibodies. Also, additionally, cases who are already on SSRI therapy and develop COVID-19 should continue their SSRIs even when hospitalized. As we have mentioned before, that most of the studies were more directed regarding the role of SSRIs. There were not enough studies regarding the role of antipsychotics in case of COVID-19. Till this paper, it was published actually this month on September 2021, discusses the role of antipsychotics against COVID-19. According to the new research, antipsychotics may protect against SARS-CoV-2 infection or lead to a milder course of illness. By studying the prevalence and prognosis of COVID-19 in 698 patients with serious mental disorders who were receiving long-acting injectable antipsychotics compared to a control group of around 500,000 individuals, both groups were followed up from February to November 2020. 4.1% of the non-serious mental disorder group were infected, while only 1.3% of the group on long-acting antipsychotics were infected. And all of them had asymptomatic illness except for one. So there were also fewer hospital admissions in those on long-acting antipsychotics, fewer ICU admissions, and fewer deaths than the control group. Of the different mechanisms of actions reported in different studies regarding the mechanism of action of antipsychotic in COVID-19 infection, the most consistent was that they reduce the activation of genes involved in many of the inflammatory and immunological pathways associated with severity of COVID-19. Another mechanism reported mainly regarding albuterol is that it can suppress the expression of inflammatory cytokines and by so preventing cytokine storm. Also, another mechanism for albuterol is that it works as 5-hydroxytryptamine 7 partial agonist, through which it can reduce the plasma levels of interleukin-1 beta, interleukin-6, and nuclear factor Kp of the lung, which were all implicated in the inflammatory pathway. And by then, studies proved as a partial agonist of hydroxytryptamine 7, it can increase the survival of cells. Another mechanism of action of antipsychotic, more specifically related to chlorpromazine, was reported in this paper published on December 2020. They found out the close structure of chlorpromazine in relation to chloroquine already used in cases of COVID. Both are cluster-independent endocytosis inhibitors, while chlorpromazine is less effective, but it has less cardiological side effects. Actually, the experiments done on models of malaria showed that chlorpromazine can potentiate the effect of chloroquine, and this is a rationale to use both simultaneously in cases of COVID-19 to potentiate the action of the other. Lastly, this paper was published on Jan 2021. It discusses different drug interactions between COVID-19 treatments and antipsychotics through an evidence from 4 databases and systemic review. It's important to have some knowledge regarding those interactions. So the main risky interactions would be the risk of QT prolongation, torsade points embracement, and cytochrome B450 interactions. So regarding the remdesivir, the baricitinib, the anakinra, all those drugs can be used with antipsychotics without the risk of drug-drug interaction, except for hematological risk that might occur between clozapine interacting with baricitinib. The favipiravir only needs caution with chlorpromazine and quetiapine. The tocilizumab is rather safe to use in combination with different antipsychotics. The riskiest COVID-19 treatments for administration with antipsychotics are the chloroquine, the hydroxychloroquine, the azithromycin, and the lopinavir. Because of the risk of QT prolongation, the torsade points, and as mentioned, cytochrome interactions. So this systemic review provides highly probable drug interactions between lopinavir plus quetiapine and ritonavir plus risperidone. According to the previous data we already stated, we are in need for more clinical trials to clarify specifically which type of patients can benefit from those drugs, at which stage of the infection should it be given that we already stated such psychotropic drugs can be beneficial for prophylaxis against the infection from the start. As we know, vaccines are of high importance, but they have some of the drawbacks as they manufacturing capabilities, storage conditions, public acceptance, and the time to administrate, besides the risk with the variants. So we are in a big need for alternative or complementary treatments and preventive approaches in the form of safe, orally available small molecules that can target, if possible, mechanisms not prone to drug resistance.